have Dr. Anindya Anuradha, who will be sharing her case, Phacoemulsification in post-RK eyes, challenges and surgical decisions. Yeah,
Thank
very
you very
interesting
much.
case.
Thank you for giving this opportunity. Can I have the videos on, please?
So this is a left eye previous RK done and the phaco surgery done and suturing of the cornea done. So this was the left eye. So now we are doing the right eye surgery. So though the left eye went uneventful, the right eye, at the end we will be showing what was the limitation. So to describe, this is a case of brown cataract, grade 4 and very shallow AC. So very difficult to manage the phaco instrument within the anterior chamber.
Can you
And very
pause the
little,
video, Dr. Anindya? Pause it, can you? So in post RK eyes, we all know that it's incisions they tend to give. So you always tend to make corneal incision, or you?
No, like a scleral incision is preferred, but because the antechamber was so shallow that pre-operatively I had already checked. So if I'll go the scleral tunnel wound, then crossing the curvature and holding it for a direct chop will be difficult. So initially I thought of going for a scleral tunnel, but because of the AC shallow, I did in the other eye the same corneal for that, and it went all fine. So I thought that this eye also go fine.
How many cuts were there?
For every quadrant, like a total was 20, very close cuts.
Why was the AC shallow?
Sir?
What was the reason why AC was shallow?
Sir, the patient had this grade 4 cataract, and in gonioscopy also the angle was extremely.
Oh, what is the axial length of this eye? Axial length and IOL power?
Okay, the IOL power was 8 for this patient.
And
like
axial length?
Axial length was 23.2. But in the myopic patient, we expect AC should be deep. That's definitely, that is something. But in this case, it was AC was extremely compromised and shallow.
Even in hard cataracts in myopic patient, AC is pretty deep actually.
AC is pretty deep, but definitely because I am a glaucoma surgeon, so I did gonio prior to surgery also, and it was very much compromised.
Okay.
I can.
Can you play the video?
Why you can see the division of the posterior part of the implant is very difficult in this scenario. And though I could have done a scleral wound, but I was really apprehensive in this case because the manipulation will be even more difficult if the scleral wound and a chamber is very shallow. So I went for a corneal wound, but it is definitely a dangerous thing when the RK wounds are so much close to each other, as you can see in this scenario. So this radial keratectomy surgery was done 30 years before this our phaco surgery, and obviously because of the chances of complication, no surgeon was ready to do the surgery. So that is why the patient had to wait so long. And at the end of this phaco surgery, you can see we are suturing the wounds because RK wound is already 90% depth. So definitely whenever we will enter to the limbus, it will open up the incisions. So we are trying to suture, however, you might notice the suture side is so small that it is very difficult to rotate the suture and bury it.
What is 9 or 10 or? Suture size? 9 or 9 or 10 or 9?
It's 10-0.
One suture was we were able to bury, but the next sutures was not that easy to bury. And the other thing is that because the RK wound is so close to each other, so while suturing, there was a corneal cheese wearing also near the wound because of the wound edema. You can notice because of this, face mouthing, how the iris is fluffy iris and the iris was prolapsed. So now we are implanting the lens. So during implantation, obviously there is a suture traction also. So the lens is implanted inside the bag, and now another third suture we are taking to close the wound to make sure there is no gap. And after that we did the IA and closed the wound properly, and all the 3 ports are closed. So now this is the post of day 1. You can see the sutures, but the level of the corneal wound is not even. So we remove the suture. However, after 10 days of removal, we landed up in this type of 1 segment corneal edema. So we went for BCM and glue. Now the patient is doing fine.
So my learning was that BCL should have been put even earlier instead of waiting for how it will work, because the wound was not even, so I had to do a premature suture removal. So once I did it, I should have put the BCL.
So it's important that you do Seidl's test, So once you suture, you do Seidl's test.
Yeah, the Seidl was negative, but
time,
it was negative.
Again, yeah.
But the wound was not properly aligned, so that's why I had to remove the suture, and yeah, that's a learning for me.
But nicely managed.
So next time you do a similar case, it will be scleral tunnel or it will be a clear corneal incision?
Sir, if this kind of AC shallow will be there, I will go again with the corneal wound and this, because I have done scleral tunnel phaco also. So the comfort of doing all the, especially using a long chopper, Nagahara chopper, in a when we are going through this, because the hold has to be really, really good. For a scleral tunnel, we never get that kind of grip in a shallow AC. But if the AC is normal, then I will go for a scleral tunnel.
So another thing is when you are struggling with bearing the knots, it is 3 to 1, right? So you use a slip knot. Slip knot are just 4 knots, 4 throws, so it goes in easily.
Okay, okay, sir. Point taken, sir. Thank you, sir.
Okay, thank you very much, Dr.